the mid-20s already.
Great.
All right, welcome everybody. Just to give a brief introduction to our speaker, and then I'll let him get started. Evan Zeitler is a nephrologist and an assistant professor at University of North Carolina in Chapel Hill. His general nephrology clinic focuses on obesity and cardiorenal diseases. And as a scientist, he's interested in better understanding the mechanisms underpinning the effects of obesity on the kidney. His work focuses on understanding how kidney cell metabolism changes in response to high caloric intake and increased adiposity, hoping to discover new pathways involved in the development of obesity-related kidney diseases. So he's promised, Swapnil, he'll throw a zebrafish in there somewhere. So we'll watch for that. And I'll turn it over to you, Evan. Thank you very much for joining us today.
Yeah, absolutely. Thank you so much, Dr. Karpinski, for the introduction. I promised Swap, and I think I promised David even more than I promised Swap that I would have some zebrafish in there. So yeah, I don't want to disappoint either of them, and very much appreciate the invitation to join you all. Know a few of you, and looking forward to talking today. So you can still see my slides, okay, Dr. Karpinski? Okay, great. And I'm just going to try and make sure everything advances. Perfect. So just before I get started, just to disclose, I have no direct financial disclosures that are relevant to this talk. Some of the work that you'll see later in the talk was supported by a T32 through the NIH Restart Training Grant here at UNC, and then the UNC Kidney Center graciously supports me still. Also, as many of you know, I'm interested in AI-generated images, so I will scatter those throughout the talk today, but I'll make sure that they're clearly marked, although many of you probably have an eye for them at this point. So what are we going to do in the next hour? Hopefully we can get it done in an hour, because I think we've set some relatively lofty goals, and if we don't get everything done, that's all right. I'll just have to come back. So overall, my goal is, sort of to convince you, there's a group of Canadian nephrologists that obesity is not only interesting, which I think it is to me, but really important to the care of your patients, and that managing obesity in the nephrology clinic is possible and also a core part of your care as a nephrologist. And to do that, I kind of want to talk about a few different things, and I want to go from epidemiology to mechanisms to patient care, which is why I think probably have set too many goals already for the hour, but we'll see what we can do. So I want to talk about the associations, epidemiologic associations, talk about what mechanisms may lead from obesity to kidney damage. And then I want to get into what I think will probably be the meat of the talk, which is talking about practical recommendations for obesity management and CKD. And then perhaps in part 4, we can get to the zebrafish. So for part 1 here, I just want to quickly talk about some of the epidemiologic associations between obesity and kidney disease. And this was really where I started my academic career, was just sort of being interested by this question of why does obesity associate with kidney disease, and actually does it associate? So I'll show the requisite slide, comparing across developed countries rates of obesity, and this is taken from the OECD and adapted a little bit, but as you can see, the United States leads the way, as we do in so many great health metrics, in terms of obesity, broken down by men and women. Over 1/3 of people have obesity, but Canada is not far behind, 21%, and you can show this in lots and lots of ways. You can show that obesity has become increasingly prevalent across the last 30 years. We can show maps, and everybody's probably seen the United States maps, where everything gets just redder and redder as more and more patients become obese. But I don't really know what a province is, so I couldn't show you province. No, just kidding. But I think we all understand that the prevalence of obesity is rising and rising, and that's a critical issue, and it's important across the entire world. Why that is would take another more than an hour. There are whole conferences, I think they convene conference in Oxford and Cambridge, about why obesity rates are rising. But if you as a nephrologist want a quick read that really breaks down, I think, a lot of the important basics, my colleague at the school down the street, Herman Ponzer, has written a really accessible, excellent book about some of his research that also kind of lays bare the underlying driving forces that have at least contributed to a good percentage of the obesity pandemic that we're currently experiencing. So I would recommend this without hesitation. It's very easy, and he's a great writer and has some really interesting research. And so for nephrology, it does turn out that this obesity pandemic is important, right? This fact that we have increasing amounts of obesity is affecting the patients that we see. And so on the left is just the figure from an AJKD article where they looked at associations between obesity with or without dysglycemia, hyperlipidemia, components of the metabolic syndrome, and the association with CKD. And whether you define that by eGFR, whether you define that by ACR or the composite, being obese, whether or not you have metabolic abnormalities that are at least clinically detectable, gives you, a hazard ratio that's not 10, but is certainly consistently in the 1.5 to 2 range for developing CKD. And that's consistent. There's some wobble, obviously, in that, as there are with all epidemiologic studies, but that's pretty consistent across studies, that whether or not you have diabetes, hypertension, hyperlipidemia, obesity itself is a risk factor for kidney disease. And on the right side, I'm just showing, again, a similar epidemiologic model, but this time for adverse cardiovascular events. And again, whether you measure obesity by waist circumference or by BMI, and there's plenty of argument about that, there's an association that's in that 1.5 to 2 range, for hazard ratios with adverse cardiovascular events, including death. And so, again, no one will be surprised by that, although there has been some debate back and forth about whether obesity itself without diabetes is associated with kidney disease. I think that data is pretty clear at this point from the epidemiology. And it kind of works across not just your general CKD patients, but also different groups of patients that you might care about or care for as a nephrologist, so your post-living donors. So if you look, again, at years after donation, and as with most of these studies, we only have about 20 years worth, although that's growing, you can see that patients who are obese at the time of donation have a significantly increased risk of ESKD following donation. Now, again, as you know, all living donors have a very low risk of ESKD. So I'm not saying that overweight or obese donors shouldn't donate, but the point is that obesity does contribute, even in what should be an extremely healthy group of people at baseline, to increased risk of ESKD. And then finally, in the world of GN, which as David knows is a big part of what we think about here at UNC, IgA is probably the best study just because it has the greatest numbers, but there are some data that suggest that obesity, again, separately from the things that we know about IgA, including MES-C scores and things like that, if you add BMI to a MES-C score, it better predicts the maximum glomerular area, in other words, glomerulomegaly, not surprisingly, as we'll talk about. But also kidney outcomes. And so if you look at patients who had a BMI of greater than 25 versus less than 25 in this single cohort, they had significantly worse kidney outcomes, even with a primary disease that we don't think of as necessarily being associated with obesity itself. So that data, again, I would hope that you all will follow along with me and agree that that's relatively convincing data, that there's at least an association between obesity and kidney disease. And so the question then becomes, and where I became more interested scientifically, is, what are the mechanisms then? If it's not just diabetes and hypertension, which we'll talk about, what are the mechanisms by which having increased adiposity leads to problems with the kidneys? And so this is the classic description. I want to go through this. What we see in patients who have obesity is what's been termed obesity-related glomerulopathy, or ORG. And that's just really nicely described in this review by Vivek Dagati and other folks. And they kind of show the classic changes that you see. So the number one thing that you see is glomerulomegaly. When you compare to a normal glomerulus here, you see glomerulomegaly, so enlargement of the glomeruli. And that's really from capillary hyperplasia. So you actually have longer capillaries, they sort of extend. You can see, less mesangial expansion than you typically see with things like diabetes, especially later in diabetes. And then this is not a very good EM image. We'll see some better ones later, but what you typically see is sort of mild foot process effacement, as you might see in diabetes or other podocytopathies, not complete effacement as you see in some glomerular diseases, but this sort of mild and patchy foot process effacement. And that's, as you might imagine, accompanied by some low-grade proteinuria. And this has kind of been the description of what we've seen going back to the 1970s when autopsy studies were done in patients with BMIs of greater than 40, 45, which were relatively more rare then, but without metabolic abnormalities. When they biopsied them, this is what was described. And I think in the years since then, we've really described a more broad set of changes that occur, especially as regards the tubules. And so I think thinking about this not so much as ORG, but ORKD, or obesity-related kidney disease, is a little bit more appropriate, because much like diabetic kidney disease doesn't just affect the glomeruli, obesity-related changes don't just affect the glomeruli. And in particular, the tubules are also affected. And what you see here is an experimental figure, where we're showing overfeeding this high-calorie diet, or a high-calorie and high-fat diet, leads to these changes in tubules with increased vacuoles and fat droplets. And you can see that where the normal proximal tubules have these beautiful mitochondria that are arrayed throughout to give them all the energy that they need to do all the things that proximal tubules do, those mitochondria you can barely even see here. They're all pushed to the side. And when you look at them up close by EM, they've lost their cristae and they're very unhealthy appearing mitochondria. So there's major tubular changes as well. The tubules get larger and filled with these fatty droplets, something that some folks have even termed fatty kidney disease. But I like to think of this as obesity-related kidney disease. So what are the mechanisms that lead from obesity to these pathologic changes that we see by biopsy and the changes that we see in patients? So I think everybody, won't be surprised to know that there are obviously these indirect mechanisms, and number 1 and 2 are hypertension and diabetes. So there are many mechanisms by which obesity leads to hypertension. I think they're nicely laid out on this slide. There's increased renin-angiotensin activation. There's increased sympathetic nervous system activation. All of those things lead to increased sodium absorption and increased blood pressure in that way. There may also be issues with compression of the renal vasculature that occurs due to visceral adiposity, and that may also lead to increased blood pressure. And then there's a lot of discussion and research into perivascular fat depots that may also influence endothelial function and vascular function in patients with obesity. And all of those things result in this kind of shift in, sort of the average blood pressure in patients who are obese, to the point where blood pressure tends to run higher in patients who are obese. And I don't think that'll be surprising to anybody. Now, I think a separate debate can be had about whether hypertension alone causes a significant amount of kidney disease, but we certainly know that in patients, for example, with diabetes, that it's a risk factor for worsening kidney function. So that's one mechanism indirect mechanism by which obesity may lead to kidney disease. It's hard to find data on the percentage of patients with obesity that have diabetes. My wife is an endocrinologist, and she and I actually looked for a while to find a really nice figure or graph that describes this well. And the best thing that I could find was this a little bit of a blurry table here from BMJ Open. But again, if you look at folks with increasing BMIs, less than 25 sort of being the reference, and then greater than 40 being, your severely obese patients, in those patients, almost half, 47% of them have either diabetes or prediabetes. They have a dysglycemia or insulin resistance. And I'm not going to spend slides talking about how diabetes affects kidney function. I think we all experience that every day in our clinics, but certainly obesity is a risk factor, probably the #1 risk factor for type 2 diabetes, and we know that how that affects kidney function. So that's certainly an indirect mechanism. But as I showed towards the beginning of the talk, neither hypertension, dysglycemia, or some of the other metabolic abnormalities account for all of the things or the amount of obesity-related kidney disease that we see in terms of the hazards that are associated with obesity. So what else may be playing a role? And I'm going to show two sort of figures that overlap in some ways that suggest other mechanisms that may be at play. So this is one by Suboi, who's in Japan, and he has done a lot of work in the area of obesity-related glomerulopathy, as he calls it, and talks about how obesity does increase hypertension, renin-angiotensin system activation, but also does these other things. So there's this dysregulation of adipokines, which are these, not cytokines, but signaling molecules that are produced in the fat that downstream can directly do things like increase renal plasma flow and increase the filtration fraction. They lead to glomerular hypofiltration, which can then lead to the podocytopathy that you see. They lead to this arteriolar dilation, including the afferent arteriole, that again can lead to glomerulomegaly. And as we know, once we start seeing damage to the podocytes and the glomeruli, that damage can reinforce itself as nephrons die, leading to increased work in each remaining nephron and then glomerular sclerosis and obviously to end-stage kidney disease. So this is a broader look at it, but in that Degati review article, they break it down a little bit more by possible mechanisms directly within these pathways. And so I want to look at this because it's a slide that I always spend a lot of time on. I think there's often a lot of questions about and debate about kind of carefully. But there's a lot going on here, is the long and short of it. And a lot of it centers around increased glomerular pressure. Where that starts and what initiates that remains unclear in the literature. One thing that's consistent is that patients with obesity, because of activation of the renin-angiotensin system, adipokine signaling, have increased proximal salt reabsorption. Again, much like you might see in patients with diabetes, where they have increased glucose delivery, and we know the story with SGLT2 that comes from that. But this increased salt reabsorption leads not just to systemic hypertension, as we discussed, but also to decreased delivery of solute to the macula densa. And when that happens, we know that the afferent arteriole will dilate and potentially lead to increased plasma flow, which leads to increased glomerular pressure. Decreased ability to adapt to increased systemic hypertension can also lead to high glomerular pressures. And then there's an effect probably of diet. We can talk for a long time about whether high protein diets really play a role in this, but certainly protein loads acutely lead to increases in glomerular pressure. Whether that's true chronically, I think remains an open question. And then again, efferent arterial constriction is occurring because of increased angiotensin II and aldosterone in these patients. So all these things combine to lead to increased glomerular pressure, which leads to more flow, mechanical stress on the podocytes, and then the sort of podocyte adaptation initially, and then apoptosis later, leading to death, and then this sort of FSGS-related phenotype. At the same time, that increased pressure leads to the capillary growth that I was discussing earlier, capillary hyperplasia that leads to the glomerulomegaly and kind of stresses out these podocytes further. But as you can see, this is still very focused on glomeruli and not tubules. It doesn't discuss ectopic lipid deposition in tubules, which clearly occurs. And there's been some recent work, most notably in JASN, showing that if you sort of improve mitochondrial function in the tubules, that may even feed back to the glomeruli and improve glomerular function, regardless of whether you actually change diabetes or obesity phenotype in mice, we should say. And so I bring up these question marks because we still don't really know, for example, what are these factors that may lead directly to afferent arterial dilation. There appear to be some factors, possibly adipokines and other things that lead directly to afferent arterial dilation. We still don't have all of the connections between adiposity and increased sodium reabsorption, even though we know that patients produce more renin-angiotensin components, and adipose tissue can produce its own versions or its own renin-angiotensin system components. We don't know What's the role of mechanosensing in the proximal tubule? I talked about lipid deposition. What's the role of that? And then one of my biggest questions, and something I'm very interested in, is there are many situations in which capillaries, grow in hyperplays, right? For example, when you take out the kidney from a living donor, we know that those kidneys and those glomeruli will get bigger. Or if you're born with a single kidney, we know that those will be larger glomeruli, and yet we don't really have podocyte dysfunction. And so why does this mismatch occur where the podocytes can't adapt to what is otherwise a change that is typically adaptable or possible to adapt to? Why do podocytes start to die in this situation? So there's a lot of open questions. And so as I was saying, there's always more to this story. These figures it's a wonderful figure, but it doesn't include everything. And so on the left, these are just two more pieces of the puzzle that I think are important to know about, but that we won't go into in detail. I'm not an immunometabolism specialist, but it's been described for years that patients with, and this is really small, but that patients with obesity-related glomerular disease have increased infiltration of inflammatory cells into the kidney and into the glomeruli. And these are tiny figures, and you're not meant to see them closely, but suffice it to say that in mice and in people, there's increased M1 macrophages in the kidneys, suggesting that there's sort of an inflammatory phenotype of macrophage infiltration into the kidneys. And on the right, I just wanted to show the effect of metabolism itself in the kidney cells. And so this is an in vitro look, but they also looked in vivo at the distribution of mitochondria in podocytes. And so HK1 is hexokinase 1, which is a glycolysis enzyme. TOM20 is a mitochondrial marker, so that's in red. And what you can see is that the glycolysis enzymes are distributed throughout the podocyte, as you might expect in the cytoplasm. And the mitochondria are really centered around the nucleus, right? And you don't really see them in these primary filopodia, which are kind of a foot process mimic in vitro. And so that was the idea, is that these authors were suggesting that really glycolysis is powering metabolism within the podocyte foot process. And then what they did here was they blocked mitochondrial function with oligomycin, or blocked glycolytic function with this PKM2 knockdown or 2-deoxyglucose. And what they showed was that actin rearranges itself, but it only does that when you block glycolysis. And this is sort of a maladaptation that's occurring when you block glycolysis. And so there's a lot of work going on to figure out how cells are adapting to metabolic changes, and suggesting that metabolic changes, as much as mechanical and structural changes, may be really, really important in the pathology that we see in obesity, and if you want to call it early diabetes as well. And so the mechanisms are many, they're broad, they're varied, and so that kind of begs the question, what to do, right? You're the nephrologist, you have a patient sitting in front of you with obesity and CKD, and the CKD may be from a completely different cause, but what should we do? So I want to make the argument, as I said at the beginning, that it's worthwhile to treat obesity in patients with CKD, and then talk through how I approach that, and hear how you approach it, and hear your thoughts on what I have to say, because disagreement is expected, especially in an area where we really don't have a lot of great data yet. But first off, if we're going to go through this work, why do I feel strongly about managing obesity and CKD? I've discussed a lot of this already, right? I think hopefully you'll agree that obesity does increase the risk of CKD and end-stage kidney disease in patients with CKD. Perhaps, more importantly, obesity worsens a lot of the things that we're trying to fix in clinic to help our patients with their kidney disease, right? It worsens your glycemic control, it worsens your hypertension, it worsens albuminuria clearly. It also increases the risk of cardiovascular disease and cardiovascular mortality. And I think as much as I'm trying to treat my patients' chronic kidney disease, prevent progression, and hopefully not, but transition them to a smooth dialysis landing or transplant if needed, I'm also worrying about their cardiovascular disease, because that's more than anything what's going to change their lives or potentially kill my patients. And it's clearly shown that interventions to treat obesity, whether that's surgery, whether that's pharmacology, and to a lesser extent, probably lifestyle changes, reduce the risks of cardiovascular disease mortality. And if those don't convince you, I think the other thing that may convince you is that you're not going to have a choice about treating obesity and CKD anymore. These are sort of rates of obesity on the left, elevated waist circumference here in the middle, and severe obesity in patients with CKD across the last few cohorts. I think from NHANES was a figure that Alex Chang made. And as you can see, the rates of severe obesity, 20% in patients with CKD, and elevated waist circumference, upwards of 70, or getting close to 70%, I should say. And so the patients in your clinic are going to be dealing with obesity, and it's going to be something that's affecting them in one way or another that affects their kidney health, their health overall. And so we're, as nephrologists, and I think we in general in practice, are not going to have a choice about treating obesity anymore. It's going to have to be a team sport, and we're going to be and can be at the forefront of that team if we want to be. And so I want to kind of go through the different aspects of obesity treatment that we can use. Okay, so we kind of break these things down, or at least in my head, I break them down as sort of lifestyle, diet, and pharmacology and surgery. And so I think, as many of you know, sort of the role that diet and exercise play in CKD prevention is very hard to study and has been very unclear. We've done plenty of diet trials, and many of them have really not shown major differences either in CKD incidence or progression. There's not very many nutrition studies really include a lot of patients with CKD, and there have been a few pilot studies that have used intensive lifestyle management, and they've been negative. But there are a couple of trials that I think are worth talking about. So on the left was a trial it was an analysis from the Look Ahead group in the Lancet a few years ago that looked at sort of intensive lifestyle versus just regular diabetes support. So these were patients with diabetes, and they were looking at the incidence of worsening kidney function in those patients. And as you can see, with intensive lifestyle, they lost a little bit more weight. They lost about 4 kilos, which is significant, for a lifestyle intervention in particular, compared to the normal, just regular diabetes education. And the incidence of severe or worsening kidney disease over the 10 years of follow-up was significantly less. And so that suggests there can be an effect of lifestyle modification, intensive exercise, and diet counseling on lowering the incidence of CKD. They had a relatively low total incidence, kind of in the 8, 9, 10% range, but there was a significant difference there. And then many of you may know the study that Don Wesson did, which is sort of represented here on the right. And this was his kind of fruits and vegetables study, right? So he's looked a lot at providing fruits and vegetables as a way of preventing CKD in at-risk populations. And this spread from the hypothesis that dietary acid loads contribute to long-term poor kidney outcomes. And so as you can see, the circles were just usual care. These were patients who had relatively poor access to healthy foods. The triangles were bicarb administration, and then the dark circles were fruit and vegetable administration. So in this study, at least, with 3 kilograms of weight loss with the fruit and vegetable group compared to both, actually, the usual care and the sodium bicarb administration, they did have an improvement in the GFR slope. Now, given the studies that have come out since then about bicarb administration and GFR slope, I do think you have to take this one with a little bit of a grain of salt, because subsequent studies haven't really shown major changes in GFR outcomes with sodium bicarb or with Veramir reducing dietary acid loads. But they did show that, at least in this cohort, providing fruits and vegetables also helped to reduce loss of GFR over a relatively short time window. So lifestyle can be effective, but more and more we're learning that the environment in which we live is forcing us to medically manage these patients. And the discussion about the built environment and the food environment that we have is, again, outside the scope of what we can talk about. But we've been forced to the point where many patients are asking for and really needing medical management of their obesity. And I think that's where nephrologists can play an increasing role. And a lot of us, many folks everywhere across specialties, have been kind of scared off of medical management of obesity because of, you know, bad experiences, trauma from the past with these older meds that, you know, were used for weight loss, and they're kind of listed here. And we'll go through these in detail. I don't want you to pay close attention to the whole table, but this is a table I pulled from another one of Alex Cheng's papers, looking at all of the adverse effects from these previously approved medications, right? Especially in our patients with CKD, you know, for naltrexone, bupropion, you know, you're going to raise the blood pressure. You may have hepatotoxicity, all these things that we worry about with phentermine, topiramate, and we worry about metabolic acidosis, sort of causing an RTA and leading to kidney stones and hypertension and all these different things that can happen with orlistat. You know, drug absorption issues, there was the issues with fatty stools and all those types of things. And so you had all of this pain associated with these medicines, both from the patient standpoint and from the provider standpoint. And the typical weight loss with all of these medicines was somewhere in the 3 to 5% range, which is not nothing. It's certainly clinically important. These meds were approved because of that, but it's not a ton of weight loss. And now, as many of you know, we're in the new world, right? I'm not going to go through all the news reports. I'm not going to go through every single journal article about kind of where we are now, but the incretin-based therapies have changed the world, right? They've changed my world, they've changed the research world, they've changed our world, and they get a lot of press, both scientifically and in the lay press, and I think there's a reason for that. I think it's justified, because what you see is just one here of many studies that have shown these incredible benefits from these medicines. The weight loss, you're probably all well aware of, but for example, with semaglutide, you know, expecting 15% weight loss is not crazy when you start this on a patient, right? With the newer meds, tirzepatide and things coming down the line, we're going to be looking at 20, 25% weight loss over the course of a year. That's insane and very close to what we get with surgical management. And more than that, and really critically for our patients, you get a ton of weight loss, which is great. And many patients are very pleased with that, and that's their primary goal. As nephrologists, I think that's rarely going to be our primary goal. But what we get is less death, right? It's kind of hard to argue with death. And this is data from the SELECT study, which was just looking at patients with obesity put onto semaglutide. And you can see, you know, they had a combined cardiovascular composite endpoint, which was improved with semaglutide. They had less death from cardiovascular causes, less heart failure, and sort of less death from any cause, right? There's very few, but there are a few, but there are very few drugs that do this and have a relatively favorable side effect profile that patients sort of like taking, which is why nobody can get any semaglutide and nobody can get any tirzepatide anymore, because these medicines are incredibly effective and provide benefit both from the patient side and the provider side. And as you can see, you know, in Canada, from, you know, the most recent data, I think this was projected, you know, starting from 2021, was across different provinces, what's the use of Ozempic, in this case semaglutide, for non-diabetes, in other words, for obesity in Canada. And this was as a percent of total claims. And so you can see in 2019, it was less than 5% across all provinces of total claims for Ozempic were for non-diabetes. And projections had it up in 2022 to, you know, 20% in Ontario. And my guess is that the reality probably far outpaces that if people are able to get Ozempic. So that's just an example. In Canada, I think that's the case, you know, across the world probably. I would be remiss, you know, if I didn't say that surgical management remains the most effective way for patients to lose weight, the most effective and durable way for patients to lose weight. These bariatric, or what they call metabolic surgeries now, are effective in patients who have chronic kidney disease, and they've been studied in enough patients that I feel confident saying that they're also safe in patients who have CKD. The outcomes are not significantly worse. And what you can see on the right is just one example of that. Best medical treatment is the BMT, and then a Roux-en-Y gastric bypass is the comparator here, and it lowers UACR, it improves A1C, cholesterol, and reduces the percentage of patients with albuminuria. Most places aren't doing a lot of Roux-en-Y anymore. They're doing more gastric sleeves and things like that. But those are also effective surgeries, and the choice of surgery, I obviously leave up to the surgeon and the patient, but across these surgeries, they are largely safe and they're very effective. I will say that, this comparison, this is, you can see from 2020, obviously was done with data from the mid 20-teens. And if you look at the patients in this particular study in terms of what best medical therapy comprised, you don't see a high percentage of GLP-1s, you don't see a high percentage of SGLT2s, you see a fair amount of insulin, and as typical, we don't see lots of ACE inhibitors, or as much as we would probably want to see in this type of population. So, comparator population may not be exactly perfect. And as you can see, there was also a lot of metformin use. And so that may change as time goes on with, these really effective GLP-1 or incretin therapies. These curves may become closer together. But suffice it to say, surgical management is safe and effective in patients with CKD. So with all of this data, as with everything in nephrology, it's kind of a blessing and a curse, right? We're having increasing amounts of studies. It's nice that we have data, but now we kind of have to sort through all this data and figure out what to do with the patient sitting in front of us. And so I try and take it back to that mechanism chart, right? How can I affect the different mechanisms that are at play in obesity-related kidney disease with the levers that I have to pull? And so starting with diet, I think diet is certainly can play a role. We can lower the salt intake in our diet. I think that is well documented to help with lowering blood pressure. We can talk a lot about increasing potassium in the diet, which I think is a really interesting direction that we're heading in, rather than just replacing or lowering salt, increasing potassium intake. Lowering protein intake, again, a lot of argument there. I do not feel strongly about that, and we'll talk about that in more detail. But I think can also help with systemic hypertension. Obviously, there are diets like the DASH diet that can help with systemic hypertension. Exercise, also excellent for improving, your long-term hypertension control. Aerobic exercise probably also helps with endothelial function and just feeling good in general. And then I'm going to go through these really quickly, and then we'll go into detail as I get through the rest of these slides. RAS inhibition, still remains a major backbone, right? Again, we're treating systemic hypertension with that, but at the same time, we're reducing glomerular pressure. The RAS inhibitors are kind of the OGs of reducing glomerular hyperfiltration, right? They've been doing it for 20 years. We know they work, and we know that the RAS system is overactivated in patients with obesity, and so targeting that directly is really critical. SGLT2s are kind of the newer kids on the block, and they target, at least you can argue, a lot of things that they target. They probably target proximal tubular metabolism as much as anything, but they definitely help to reduce the issue of afferent arterial dilation by increasing the delivery of solute to the distal tubule, and that's one mechanism by which they help to reduce glomerular hyperfiltration. The GLP-1, so the mechanisms by which they work, still kind of being figured out. They definitely cause a natriuresis. They definitely reduce albuminuria, probably by a similar mechanism to which SGLT2 work. But they also improve things like the peritubular oncotic pressure. They reduce, insulin secretion and increase insulin sensitivity, and may help in that way. And then mineralocorticoid receptor antagonists, right? As I said or briefly mentioned, adipose tissue can make its own renin-angiotensin component, and so blocking downstream of that, blocking aldosterone, may also be a critical way. So these aren't things that are, I doubt I'm blowing anyone's mind with any of this, right? These are, backbone of therapy for many of our CKD patients, but I think it's important to look at how they may play different roles in patients with obesity. So I kind of put together this is a purely personal diagram algorithm that I kind of think of when I see patients in my clinic with obesity. So I want to spend a little bit of time on it. And it's based on what we just went through. But if I see a patient, with obesity, so, BMI of 30, most of my patients, BMI of 35 or more, or sometimes, less so, but sometimes even if they're just overweight in the 25 to 30 range, but have a clear obesity-related complication, I start to think about what are all of the things I'm going to do. I think one place where we failed in the past is we said, okay, let's do diet and lifestyle for 6 weeks, and then 6 weeks becomes 6 months, right? And still the patient's not lost weight, or they've lost a little bit of weight, and so we kind of sit on our hands and have some therapeutic inertia about that. What I would suggest is more of a synchronous approach. Let's do it all. Let's do it all at once. And the reason for that is, again, to avoid therapeutic inertia, but also to get the patient momentum, belief going, and to start the benefits of these interventions as quickly as possible. So when I see these patients, I do start with diet guidance and guidance about exercise. I try to keep everything as simple as possible because we are going to do a lot, even in that first visit, to think about how we can improve their health and their life. I don't get into, I try to talk about a little bit about salt and reducing salt as much as possible, but also trying to eat a healthful diet that's broad and fresh and will, hopefully avoid processed foods and increase their potassium just by the foods that they're eating, rather than focusing on those things. I don't focus over much on protein intake, and I emphasize that small changes are beneficial. I start to manage, the complications of their obesity, which is, I think, something that many of you will be quite comfortable with already, obviously managing hypertension. I think a lot about obstructive sleep apnea in my patients because it's much more common in patients with obesity. I look for and treat hyperaldosteronism aggressively. And then I also know that if we start to lose a lot of weight, we may need to adjust blood pressure medicines actually relatively quickly. I've had plenty of patients who came in or messaged me on Epic and said, oh, my blood pressure is running in the 100s now. I've lost 20 pounds. And all of a sudden, we don't need as much blood pressure medicine. I've gotten increasingly comfortable with adjusting patients' insulin when we start some of these medicines, and we can talk about, how to do that. Obviously, using SGLT2 inhibitors wherever possible, but certainly in patients with diabetes. And then not forgetting that metformin in patients who have a GFR greater than 30, metformin is not fancy and it's not new and it's not cool, but it is still the backbone of diabetes therapy and probably has some cardiovascular benefit, even though it really hasn't been studied for that. And then I think about all of these things managing the patient's cardiovascular disease risk. This might really be more of an overarching goal, right? Exercise, diet, hypertension control, diabetes control, all are going to help manage cardiovascular disease risk. So recognizing that our interventions for CKD are really cardiovascular disease interventions. And then, relatively aggressive lipid management with statins, although most of my patients come to me already on that. And then when it comes to, kind of what I will do in clinic as far as starting some of these high efficacy treatments, the approved medicines currently for weight loss alone are higher dose liraglutide, semaglutide, and tirzepatide. And I start those at the doses that are listed here. I talk to patients at length about what they might experience, especially GI issues. We talk through any changes in their current diabetes medicines, including lowering their insulin by 10 to 20%, depending on their glycemic control. And then we come up with a plan to titrate up, for the patient to titrate up on their own. So I don't wait a month and have them come back. I write a prescription that titrates up the dose as long as they're doing well. They talk to the pharmacist and they can slowly go up on their own doses, with goals for weight loss indications for liraglutide of 3 milligrams, semaglutide 2.4, and tirzepatide of 15. You titrate those based on the dosing. So liraglutide, we titrate usually weekly because that's a daily dose. Semaglutide and tirzepatide, we titrate every month or so. And the slower you go, the less likely you are to have GI side effects, not surprisingly. And we experience this a lot, if there's intolerance, no supply, lack of access, it's really only then that I'm getting into these second-line therapies. And if I'm honest, I don't expect most nephrologists to want or prescribe these. And at that point, if you have a multidisciplinary team that you can refer to, I think that is, a great, if you have a medical obesity management clinic, that's at that point maybe refer to them. But these are medicines you can use in patients with CKD with the adjustments we talked about. And so going into more detail, I think I've really said these things, but I wanted to have them on the slides for folks who need to follow up later. You know, I try to keep my dietary advice simple, and there's a book by Michael Pollan called The Omnivore's Dilemma, and he talks a lot about keeping dietary advice simple. He says, eat food, right? Eat whole foods. Don't eat nutrients. Don't eat this specific nutrient or that specific nutrient, but eat whole food, things that your grandma would recognize as food. Would she recognize a Pop-Tart? I don't know, but eat whole foods. Don't eat too much. Small plates, small bowls, keep the portions small, and eat mostly plants. I don't tell my patients they have to be vegetarians, and there's, again, argument about this, but when you look across nutrition studies, these are the things that come out. Don't eat, there's no specific diet that's perfect for everyone, even for patients with kidney disease. Don't eat too much. Don't eat overly processed stuff. Mostly eat plants, and that's going to take care of sodium intake, potassium intake, salt, protein intake. It's going to take care of all these issues without overwhelming the patient with specifics. And they have to be things that patients can do forever, right? It's great to lose 50 pounds by not eating anything. Well, it's probably not great, but it's not sustainable, and it has to be sustainable. And then, as I said, avoiding processed foods as much as possible. We could talk about the social difficulties with that, and how you help patients who have, may not have access to fresher foods. And then, as I said, don't overemphasize any specific macronutrient. Exercise-wise, again, I emphasize small changes. Walk, stand instead of sitting, making these little changes. And critically, that exercise is not going to help or make patients lose weight. You cannot outrun a bad diet, as they say. And that's one of the ironies of all of this, is we've always taught exercise as a way to lose weight, and you can't outrun a bad diet. You will not lose weight if you're eating too much. But also that exercise is totally critical for your longevity, for your heart health, probably for your kidney health, for all these other things, for your mood, for reducing your appetite, for doing all these things that we do want. And so it's one of the most important interventions we can do, but just don't expect it to make you lose weight. And then again, just emphasizing that these are long-term changes. So little things that you can do every day are much more important than big things that you only do for a couple weeks. From the medical management side, I've talked a fair amount about that, but actively looking for untreated sleep apnea, reassessing how well patients are losing weight at every visit and not having therapeutic momentum. So expecting in the first 6 weeks, 3 to 4 to 5% weight loss on these newer medicines, and if they're not achieving that, wondering why, whether it's a dosing issue, adherence issue, or just a drug issue. And then if patients are really not meeting their goals despite maxing out the medical therapy, referring to my colleagues in metabolic surgery. I won't belabor this, but putting it here just for ease of access for folks. Again, the dosing, the starting dose, the titration for the 3 approved medicines for weight loss, 3 incretin approved medicines, and just remembering that contraindications for these are history of pancreatitis or history of multiple endocrine neoplasia. We talk about adjusting insulin, and we can go through that as well. And then none of these, as of right now, have any adjustment for kidney function. Whether they work in patients with end-stage kidney disease, they do seem to work. They seem to be safe. Again, as with end-stage kidney disease, across the board, relatively little data. And I'll skip over this slide as well, but this is just a nice breakdown of kind of my approach to the secondary medicines and the order in which I would potentially use them, and adjustments for GFR if needed. But again, the only one that I commonly prescribe would be the phentermine topiramate combo, and I have had relatively good success with that outside of using the GLP-1s. So what do I worry about when I'm treating patients for obesity? There's a lot of things that people bring up as worries that I don't worry about so much. The obesity paradox, the idea that patients on dialysis do better when they're obese, I think it is true in the sense that it exists statistically. I'm not convinced that making patients obese on dialysis makes them healthier. I think there's a lot of confounders there. And so I think healthier folks tend to be able to maintain weight on dialysis. And so I don't worry so much about weight loss in CKD or dialysis if it's intentional and targeted at reducing CVD risk. I do worry a little bit about micronutrient deficiencies, especially in the setting of surgical weight loss, which can be really rapid. And I think taking a multivitamin taking iron, taking B12, those types of things may be necessary for some of those patients. And I also do worry a little bit again in the setting of especially Roux-en-Y bypass about increased stone risks and hyperoxaluria that can occur. And I worry about that with phentermine as well. But not as much as I worry about these other things. So obviously we worry and have to deal a lot with affordability and adherence and fighting insurance companies. And that's just something that will slowly over time get better, and it may be very different for you all in your system. I worry a lot about this rebound weight gain, because when patients, lose weight, they feel better, they want to stop taking the medicine, the data is really good that they will regain most, if not all, of the weight that they've lost on the incretin therapies. And so understanding this is treatment for a chronic disease. This is not one and done. This is not a few months. This is probably treatment for a chronic disease, a new medicine that's likely to be lifelong. And then I really worry a lot about sarcopenia. I do think patients mostly lose fat mass with these medicines, but they also lose some lean mass. And so I talk to them a lot about exercise and maintaining some resistance exercise as they're losing weight, because losing a bunch of fat, if you're also losing muscle, is not going to help you from the standpoint of functionality, and probably long-term is really not healthy. And so I talk a lot about resistance exercise as well as aerobic exercise with these patients to maintain their lean muscle mass. So as I said, that was the bulk of my talk. What's coming down the line is, I think, incredibly exciting. We have retatrutide, which is a triple agonist. We have oral GLP-1s, which are going to be incredibly effective. This is just the beginning. I think we're going to be expecting meds now to cause 20 to 30% weight loss and improve CVD outcomes. And I put this river here because the FLOW trial has just been stopped early, and we should see kidney disease outcomes, hard kidney disease outcomes, presented at ERA in May for semaglutide. And so that will be really exciting, because we've had lots of hints that these will improve kidney disease and kidney function in patients with diabetes and obesity, but no hard outcomes. And so that data will be presented soon. Nice. And then in the summer or fall, the ASN is going to put out what's called kidney health guidance. The first of those is going to be about obesity management and CKD. And so I'm currently on the working group that's going to develop this guidance for nephrologists treating patients with obesity. And so that will be coming, and we'll have some specific guidance, not a guideline per se, but just some guidance, expert consensus and guidance on how to treat patients with CKD and obesity. And so I see that I have 5 minutes left. I knew that I wouldn't get through everything, but I do, I promised David, I promised Swap that we would talk about zebrafish. And so we'll do that at least with, 3 minutes, and I'll try to leave a couple minutes for questions. So I want to talk about, my interest and my work, which is in understanding, broader mechanisms of obesity-related glomerulopathy or obesity-related kidney disease. And so there are lots of animal models of obesity. Most of them rely on genetics, alterations, and that's one limitation that they have. And through a story that's longer than I can tell here, I got sort of wrapped up in working with zebrafish as a new model for this. And the nice thing is, as you can tell, they're tiny. There's probably several hundred zebrafish and just in these little tanks right here, which is a lot more than you could fit in the same space if you were working with mice or obviously any larger animals. They replicate a lot of the human kidney in their little tiny kidneys, especially the things that we care about, the glomerulus and the proximal tubule. They have excellent gene homology with humans, and because of some of the limitations of rodent models, in particular with diet, the zebrafish are a really nice complement to rodent models for obesity. And so, as you can see, this is just a beautiful image that Max Schindler took for me of one of the zebrafish kidneys, and he's labeled nephrin here. And if you weren't told otherwise, you might think that this was an IF from a human kidney biopsy, right? You have beautiful sort of podocyte basement membrane labeling of nephrin along this glomerulus at high power. And then you can also see proximal tubules, which aren't really specifically labeled here. And so zebrafish have, especially glomeruli and proximal tubules, that really replicate what we see in people. What can you learn from them? Well, that's what we're starting to uncover. So I have given these fish high-calorie diets and made them obese, and what you're seeing here is a wide field fluorescence image of the whole kidney. So this is a whole zebrafish kidney outlined here. And in red, I have a fluorescence labeled glomerulus. So this is obviously much lower power, but you can see all those little dots are glomeruli. And each fish has somewhere between 200 and 300 glomeruli per kidney. And there's sort of an expected concentration. Well, when we start to give them a high calorie diet, the kidney, as it does in people, gets slightly larger, and the number of glomeruli goes down. So the glomerular density actually starts to go down. You can see that there are just fewer glomeruli per area in these high calorie diet fish. And that's something that we're exploring, why that may happen, and why don't these fish respond by growing more glomeruli. And the other beautiful thing that we can do that we can't do in people is use transgenics. And so again, at higher power, we have these glomeruli that can be labeled, and then we can look at changes in pathology. We can look at the number of podocytes. We can look at the size of the glomerulus, and we can look at podocytes per glomerular size and really explore in vivo what's happening with changes that occur in obesity. And so we've done that. So here's, I think, David's favorite slide probably. These are my fat fish. And so up on the top left, you have normal diet. You have fish that we fed a high fat diet. We had fish we fed a high calorie diet, and we had fish that we fed a high calorie and high fat diet. And suffice it to say that obviously high calorie diets make fish bigger, they make them obese. And when you do that, you see all the changes that you see in patients with obesity. So you see glomerulomegaly, and you actually see foot process effacement when you do EM on them. So you have nice normal foot processes here. In the high calorie diet, you have foot process effacement, and high calorie, high fat, you have foot process effacement as well as thickening of the GBM. And so when you give a fish a cookie, they get fat, their kidneys get fat, and they have these changes that we see in people. So what underlies that? We did metabolomics to explore that and found that kidney metabolism, so metabolites in the kidney are altered. There were about 600 metabolites from kidney tissue that were altered. So specifically within the kidney tissue, the metabolism is changing. And when you kind of go through the algorithmic approach to figuring out what pathways are effective, maybe not surprisingly, glycolysis was the most effective pathway, along with fatty acid synthesis. And so kind of future work that I'm working on grant writing for right now is going to explore how changes, especially in glycolysis, in the kidney affect kidney function. And so we'll do that. We're developing and have developed kidney organoids that we can use to study this issue and changing glycolytic function in kidney organoids and looking at podocyte function. And then we're also going to be looking at human kidney tissue samples, hopefully using spatial transcriptomics to look at changes in glycolysis in the setting of obesity-related kidney disease in patients. So I thank all the people that have helped me get to this point, excellent mentors, Ron Falk and Kathleen Corona here, Jenny Flythe here, Amy Model, who many of you may know, and then my mentors in the lab, and Susan Sumner, who helped us with the metabolomics. And sorry to rush through all this. Obviously, thanks to David, thanks to SWAP for inviting me. This is David looking, at his happiest here on a bike here in North Carolina. I'll end there because I'm out of time. This is what the AI thinks UNC Chapel Hill looks like, which looks pretty nice, but honestly, I have to say, I think that the real thing, and David can tell you whether he agrees, I think the real thing is actually a lot nicer. So right at 9 o'clock, I rushed through the end, but happy to answer any questions if there are any, or take more time if there is. I'm going to stop. I guess I'll stop sharing.
Well, thanks for staying on a bit if you can, Evan. I think some people might have to rush off to clinic, but we've got a few questions going. So, and thanks also for throwing in that.
I'm sorry, hang on one second. I lost my audio. Sorry, can you try again, Dr. Karpinski?
Oh, okay.
There we go. Yeah.
Okay, perfect. I just want to thank you for the little bit of Canadian data that you showed there on the provinces. Much appreciated.
Of course.
So, Anne's had her hand up for 6 minutes and turned her camera on, so she gets to go first.
I think I saw that, and then I was like, I got to rush, I got to go. So.
Yeah.
Oh, sorry about that.
No, my fault.
No, thank you for an excellent talk, and I did particularly enjoy the zebrafish as well, because I think understanding mechanisms is really important. I look after potential kidney donors and kidney donors, and we know in this group as well that their weight rebounds when they lose weight for kidney donation.
Yeah.
But as we gather real world data on the use of GLP-1 receptor agonists, and know that these are drugs that we're going to have to use lifelong, the average kidney donor is in their 40s. would you advocate for the use of these drugs long term? Because I think there's increasing data now about the risks of pancreatitis and bowel obstruction, and just even thinking physiologically, like we're making the pancreas, secrete insulin. What are your thoughts on that, at least based on the data we currently have?
Yeah, I agree. I mean, we don't have long-term data, right? I mean, these drugs have only really been around for 10 years when you talk about exenatide, right? Maybe a little over 10 years, 15 years. And so I think that concern is real, and I agree that's a great direction for research to go. My concern with so far the safety data is great. I think the question for like your patients where they're losing weight for a specific reason to get to sort of a safe weight for surgery, I think it's gonna, as always, depend on the patient, right? If that patient has, struggled with obesity or obesity and hypertension, then you have to think about what the benefit is to them, right? Because I didn't go through all the data, but in these folks, it does reduce cardiovascular death, which to me, that's the number one thing that we worry about, even in kidney donors. Against the worries about sarcopenia, which I think is actually, that's my biggest sort of intermediate term worry, is that folks are losing too much lean mass. I haven't seen a ton of pancreatitis, although it apparently occurs. And so how do we weigh those things? I think it depends on the patient, what they've gained, what the benefit is to them personally beyond living kidney donation, and discussion with them about the risks that we don't know of. I mean, I think it's hard to answer that question without the data. I think the post-marketing sort of surveillance on these medicines is going to help answer that. I have not seen, and I'm not an endocrinologist, but I have not seen a ton of pancreatitis. I have not seen a lot of the bowel obstructions. You see some GI, it's more, I've seen actually more diarrhea and nausea and things like that. But yeah, long term, I think those are all things we need to worry about. And I do worry about these things. I would, I guess, emphasize, this is my personal opinion more than data, is that, we don't hesitate to treat hypertension chronically, right? And we, there's risks that come with antihypertensives as well. We don't hesitate to treat hyperlipidemia chronically, right? And there's risks that come with statins, and there's risks that come with those things. And for some reason, obesity is different. I have my thoughts about why obesity is different, and I'm sure everybody has their own thoughts about why we treat obesity differently. But I do think it's a personal bias. It is a disease of social disparity, right? That's part of it. And also, it forces us to face up to the fact that we've created this society and environment where, half our population is essentially unhealthy. And now we have a weapon to sort of at least fight the consequences of that. And I think that's great. I think we need to make change upstream so we don't have to get to this point, which is a whole other argument. But so I think I think we'll become increasingly comfortable with treating obesity as a chronic disease is kind of where I think we're going with this. But yeah, I definitely think risks come along with that. I don't think there's unfortunately, no magic, no golden bullet. Although this is as close as we get, I think, in my opinion. I think like these and SGLT2s are as close as I've seen to relatively minimal risk with very high reward for us in nephrology in particular.
Thanks, Evan. I've got the conference room as well. Thanks, Anne.
Yeah, thanks, Evan.
Yeah, of course. Oh.
Go ahead, conference room. Oh, they got booted out.
Oh, they got kicked out.
Yeah.
Okay, wait, can you hear me?
You're back. You're back.
Yeah, we somehow just cut off. Sorry about that. But yeah, thanks for that really great talk and showing that, plugging in that zebrafish slides and images, really nice images and nice to understand the physiology. I had a question. It was interesting to see when you were talking about the mechanisms, you brought up that, the adipose tissue itself might have an impact and that doesn't seem clear in the science right now. But I wondered, have you come across any studies looking in, let's say high-level Olympic weightlifters or stuff like that often have short stature, very high muscle mass, and that probably have high BMIs? Is there anything to suggest that they might have the same risk, or perhaps if you don't see that, well then And that's taking away the possible testosterone use or something like that.
I was going to say, we don't know who's using anabolic steroids.
Yeah, but like, let's say just based on lean muscle mass.
No, I have not seen that. I don't know if anybody's looked, because I don't know if those folks are wanting to get biopsied or not. But that's a great question. I agree. I guess I didn't mean to express that we don't know whether it's the adipose tissue itself. I think it's clear that like increased waist circumference, increased visceral fat definitely associates with albuminuria, increased sodium absorption, those things. Like it is the fat, and it's probably the visceral fat. The question is more why? What is it about the fat? Is it everything? Is it the mass of the fat? Is it adipokines? Is it inflammation? It's probably all of these things, but are there specific mechanisms that we can pull out? But it would be great. It would be super interesting to see. And the comparison that I was making is this, your question is really about healthy versus unhealthy hyperfiltration, right? Like you have somebody who's bigger, who in theory has an increased need for glomerular capacity. Why don't those people get kidney disease, or do they? I don't think we really know. And that's sort of the same question as, okay, why do most living donors have glomerulomegaly, but not proteinuria, right? And not a higher risk of end-stage kidney disease. Sure, they're starting out at a lower risk than the general population, but they do have glomerulomegaly. Why is that not a problem for them? Why are their podocytes seem to be fine with that? And so that's something I'll hopefully explore as part of my K project, is sort of healthy versus unhealthy glomerular hypertrophy or hyperplasia. But I have to have money to do that.
Thanks, Evan. And I agree. The real Chapel Hill landmark, the well looks a lot nicer than the AI images.
Yeah.
So,
yeah.
Especially in the fall time with the colors.
This time of year, right? Too, in the spring.
Yeah, that's true. Yeah.
And there's a question from the chat as well, Evan. Dylan's asking, with respect to the zebrafish or high calorie data, do we know what's happening systemically? For example, blood vessels, endocrine, liver health. Basically, is there evidence for direct injury versus a secondary effect?
Yeah. That's a great question. So that's something I want to explore more. We, as you can imagine, it's difficult to, check blood pressure in zebrafish. People have done it amazingly. I think that person should probably win the Nobel Prize. I can tell you the average blood pressure in a zebrafish is 2/0.5 millimeters of mercury. And I don't know how it changes in my fish. So yeah, they do. I mean, we know when you overfeed fish, they deposit more fat all over. They can get fatty liver. And I've not looked at that in my fish because it's not my focus, but we know it can happen. They don't have diabetes, so we've checked fasting glucoses, so they don't have diabetes. They may have some insulin resistance and things like that. So there definitely is systemic effects of overfeeding. How adipose tissue may be directly influencing them. I think my hypothesis is that we're really causing systemic insulin resistance through obesity. That's leading to inhibited glycolysis in the podocytes, which is kind of critical for their health. And that's what we'll explore a little bit. But yeah, I think it's a combination of systemic effects and direct effects. But it's a great question. I can't tell you which one is predominating.
You got a thumbs up for the answer. Thanks a lot.
Good. Yeah,
okay.
Of course. Pleasure.
Anyone else? I've got one more, but people can go away because it's just for me.
Yeah.
When you have kind of your synchronous therapy approach, right?
Yeah.
Diet, lifestyle, all the way through. How far do you go down the CKD route for patients who are obese, but let's say have, really minimal evidence of CKD? So a creatinine that's normal, maybe normal high blood pressure, but maybe that kind of microalbuminuria that, sometimes we see with patients with obesity. So how far do you go down that kind of CKD route in those patients? Because that's really saying that I think hyperfiltration's a problem here. Yeah.
Ooh, that's maybe a philosophical question as much as I do think it's like one of those things where when you see it, it becomes your major focus, right? I do think hyperfiltration, right? I think if we had a population screening method for hyperfiltration that was reliable and accurate and with accessible interventions, you know, we'd obviously prevent a lot of diabetic kidney disease, but I think we'd prevent a lot of kidney disease in general. I have no evidence for that. That's my feeling about it. So yeah, so if I see, I do get referrals. I'll get referrals for, you know, patients with obesity, creatinine of, you know, 0.8, and albuminuria maybe a gram, a little more than just a little bit, but you know, a gram of proteinuria, which is, that to me is concerning enough that if you let it go, especially it's a lot of young patients, right? It's 35, 40, and you know, they hopefully have 50 years to live. I do worry about that, and I think there's enough evidence in those people that albuminuria is a marker of cardiovascular risk too. And so in my mind, it's less for the CKD, right? It may prevent CKD, but it's less for the CKD than it is for overall cardiovascular health. And oftentimes those patients, I don't force them, but if they want to lose weight, I say, I think that will help you, yes, and here's some ways that we can do it. So I don't push it, and again, I don't say this is going to save your kidneys, but I do think it will reduce their long-term cardiovascular risk, and hopefully along with that comes, you know, kidney disease prevention.
Yeah.
So that's my approach.
I'm hearing you push the diet, exercise, maybe the lipids, maybe the weight loss drugs, but not necessarily the ACE inhibitor.
If they're hypertensive, certainly I would start with an ACE inhibitor. Yeah, sure, absolutely. I mean, I should be clear, like all of these studies were done with a backbone of diet and exercise, you know, on, you know, medical therapy. Like I am all about if we can get it under control with diet, exercise, treatment of sleep apnea, ACE inhibitor, I'm on board with that. But I tend to see the people when that hasn't worked.
Yeah, right.
And so then it's like, okay, now we need to push a little bit. And it is all these things. Again, if we want to get really philosophical about it, what I think actually is happening with the GLP-1s, they have biologic effects, but they have a lot of their biologic effects in the central nervous system, right? And so what they're doing is they're making diet and exercise more effective. Not that diet and exercise don't work when you adhere to them, but they're hard to adhere to, even the best of us. And so along with all the beneficial biological effects, they block some of these reward pathways and just make it easier to do the things you're supposed to do. People talk about this food noise that they used to have, where they're always thinking about food. They're always trying to avoid food because if they see it, they're going to eat it. They're this food noise, and it goes away. And it's this really fascinating thing. And so I think that's why I like the synchronous approach, because it sort of is like, okay, I'm going to use the Ozempic to facilitate a healthier lifestyle. And that's what I've seen over and over, is I get these patients started down the road and they're like, oh my God, I feel so much better. I'm exercising. I've lost weight and that's great, but it's like, I feel better. I'm doing the things I want to do again. And hopefully that's reducing my risk of stroke and heart attack and making me a transplant candidate and all the things that we like, but also making them feel better. I say consistently, I don't think I've ever prescribed a medicine that so frequently patients come back to me and say, thank you for prescribing that medicine, right? Because it just not always, but it like changes how they feel. And so there are risks, and I think that was a great first question. Like there are definitely risks to the chronic treatment, and we need to be cognizant of that. But